We are progressing. We are slowly progressing into the allied information, all that we need to know. Okay, so as we have been seeing the various important symptom management, and various elements of palliative care. Now, the next few sessions are also going to be important allied information, what is to be gained, the knowledge, skill, everything from other specialties also have to be obtained to make an overall complete palliative care department service or provision. From that point of view, we have with us today Ms. Devika, who is going to take us through the important elements of psychosocial issues. She has obtained her bachelor's degree she has obtained a bachelor's degree in communication, and also done her master's in social work from Prasanna School of Public Health, Manipal Academy, and has been working in various different specialities to obtain and widen her knowledge and skill. She has worked in the Regional Cancer Center and also in the Department of Pediatric Oncology and Hematology, and in Manipal. And she's been with Palim India too. So she is going to be taking us through the important elements of psychosocial issues, which we need to be aware of and master when we are providing the palliative care service. Over to you, Ms. Devika.
Yes, thank you, ma'am. Thank you so much for that introduction. Am I audible?
Yes, go ahead.
All right. So, good evening, everyone. I'm so grateful to have this opportunity to, in fact, talk about the psychosocial care aspects in palliative care. Well, I will be sharing a screen right now.
Yes, we can see, dear. Go ahead.
Right. So, today we are completely going to see what is the need and importance of psychosocial aspects, the psychosocial need in palliative care. So, before just going to start the session, I would like to just tell that I'm not going to read the whole PPT or just go through the PPT alone, but I'm going to put some examples into it so that it will be more convenient and for you to understand what is the actual need of psychosocial aspects of care in palliative care. So before that, I would like to start with, so it's been going to be 1 year since I started working at Palim India. So right now I'm in charge of the IP and we have a halfway home. Before that, I used to work at Government Medical College, Trivandrum. And we do have a palliative care OP from 1 p.m. to 4 p.m. there. So I served around like almost 8 months. Now, as you can see in government medical colleges, medical hospitals, you can see there are a lot of vulnerable patients who comes there every day. So for that itself, I would like to put in a lot of examples that I had witnessed throughout my journey, and I'm going to connect it with the PPT that I have so that it would be more easier for you to understand. Now, so as you see, according to World Health Organization, I really don't have to, explain all this. I hope everyone knows about it, but I'll just go read through it. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering. Um, so like for patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, which includes physical, psychosocial, and spiritual. So this is what we are going to give more stress into: physical, psychosocial, and spiritual. Now let's see why is psychosocial care so important in palliative care. So before going through this, I would like some of you to just give an idea. Why do you think, as apart from any other care or the treatment, why is psychosocial or psychological, emotional, social care is very important in palliative care? Can someone give me an idea? Why do you think so? It's so important and relevant in palliative care. I want this to be an interactive session, not like I am the only person who will be talking. So it's going to be a little more interactive. Anyone? Or
They need psychosocial support to overcome their depression and uh, for a mental well-being till they survive.
excellent, excellent. That's one among a lot of other things. Yes, exactly. That's a very important part of it. Anyone else?
There are a few messages in the chat box also.
Yes, yes.
You're happy to see them, or you're okay to see them, right?
Yes, ma'am. Yes.
Okay then.
A healthy state of mind lies in a healthy body, you know. It decides the health of the, it has an impact on the health of the body.
Yeah, reduces social stress. The spirit is an economy. All the efforts would be futile. Okay, good. All right. So, why is psychosocial so important in palliative care? So, as you know that when comes in palliative care, the patients comes with either life-limiting or life-threatening illness. And they have this awareness of approaching death, which causes a lot of stress and other challenges on the journey. So that's what we see. So especially when I work in palliative care, I see people with stroke, with paraplegic patients, quadriplegic patients, then cancer patients who have very few days to live, and that we call as EOL, end of life care. So when patients who comes with stage 4 of cancer with mets and have few days to live, we call it as EOL, end of life. So these are considered to be the life-limiting or life-threatening illness, and they don't have any idea what is next, what is their future. And this awareness of approaching death, it causes stress and other challenges on their journey. So what we basically do is that we help them overcome the challenges. We go through their journey. We help them throughout their journey. So understanding, in order for that, understanding the factors related to a patient's quality of life is very important in order to provide that care. So we give more importance to the quality of life of the patient. So if we need to provide a quality of life to the patient, it is also essential to understand what are the factors related to that. So only after understanding the factors related to it, we can give the proper care for it, right? Now, there's another term called social diagnosis. It's an understanding of psychological, biological, social, and environmental factors operating on the person in his situation. Now, a person that comes with life-limiting disease or life-threatening illness, it's just not the physical pain that they go through. They go through psychological pain, biological, social, and environmental factors. These all is connected with the patient during the situation. And a serious illness disrupts the individual's thoughts, feelings, relationships, social and spiritual supports, financial stability, and spirituality. So this is why psychosocial care is very, very important in palliative care. So people with life-limiting or life-threatening illness, it's not just affecting their physical health. It affects his whole thoughts, feelings, their relationship with other people, probably the relationship with relatives, neighbors, and also social relationship, spiritual supports, financial stability, spirituality. So, what is total pain? So, when a patient reports his or her subjective pain on the pain scale, it is important to remember that the physical pain reported by a patient is compounded by his or her current life circumstances. So, as a clinician or a social worker, my responsibility is to assess the contributive factors leading to the total pain. So, now we are going to see what is total pain. I'm going to show you now, coming in the next slide, I'm going to demonstrate what is total pain. So, total pain combines of physical, psychological, socio-economic, spiritual. So, remember when it comes to palliative care sector, it's not just the, yes, obviously most of the patients come with pain management. So, for example, while I was working with government medical college in the palliative OP, so most of the patients are being referred by the radiotherapy department. And they are being referred with pain management. And people do not have any idea what is in fact palliative care. People think that palliative care is something which can reduce my pain or completely remove my pain. So this is what the knowledge the patients have. They do not know what is exactly a palliative care, what type of palliative care we provide to the patients. Now, they think it's just physical, but it is not. So that's what makes the work that we do here in Pallium India differs from the other organization or institutions. We look into the whole factor, the whole total pain of a patient. Coming to psychological. So a patient, well, for example, a patient with cancer, they come with physical pain. Yes, they'll be having psychological pain. They'll have socioeconomic and spiritual pain. So these are the four pain which compares to the total pain. So anyone has any doubt regarding this total pain? Shall we move on to the next slide? Yes. Now, so before going to this, let me put into this. So as I said, we have a way of doing assessment to the patients. So as I said, while I was working in the medical college, every day we used to get like 3 to 4 new patients. As I said, they've been referred by the radiotherapy department and also from other departments. So usually when a patient comes, we do not directly talk about their physical pain, but we do have a casual conversation with them, making sure that they do not feel that they're going through a very difficult situation. We understand them from their body language, we understand from their facial expressions. So the initial process is that we do a basic initial assessment. So this is like it's like a team, a multidisciplinary team. It consists of a doctor, it consists of a nurse and a social worker. Also, there are psychologists and pharmacists, physiotherapists. But usually, when it comes to the assessment part, we have a doctor, nurse, and they comes under the clinical team, and then the social worker. So we do have a format of taking assessment of the patient, so an initial assessment. So that will come in the next slide. So what is the aim of assessment? It is to identify problem areas which result from the illness and may influence the well-being of patients and their family. I think one of you have told this already, the well-being of patients and their families. Yes, exactly. So the whole aim of the assessment is to identify where are the problem areas, not just physical, but as I said, it comes under psychological, social, economic, and spiritual, which results from the illness and may influence the well-being of the patients. Now, this assessment involves collecting their information, identifying and honoring strength, resources, and needs. Assessment and the gathering of information is an ongoing process. So it's not like the first time patient comes and then we do the assessment, the initial assessment, and then it's over. No. So what we basically do here is that we have this continuous process of assessment. We have a continuous process of the follow-up. Maybe we'll do a weekly follow-up, we'll gather information, because every time we talk to the patient, we're getting more information about the patient. We are getting to know more about the patient. So that's how this assessment process is going on. So for that, it's an ongoing process. Now, the selection of goals and interventions depends largely on what is being assessed. So only if we can do an intervention on the problem that we've assessed, so we need to do this whole assessment. So in the end, we'll come with the conclusion that, okay, this is the major problem area where we need to do the intervention. Now, the psychosocial needs of patients and families or caregivers often change over the course of illness. So, for example, so it won't be the same way that we first do the initial assessment. Probably, for example, in the initial process when the patient or the caregiver comes to know about the diagnosis. So it usually happens in medical college most of the time. For example, when a new patient comes, they directly come to the social worker, the social welfare officer, because we are doing the initial assessment. So most of the times, what I witness there in the OP is that patients come without knowing the diagnosis. And usually, at some times, even the caregiver would not know the diagnosis. But also at this other times, they have a little idea that this is something related to cancer, but the biopsy results are not out. So we don't know, we're not sure about it. On the other hand, there are other situations where the patients and the caregiver, or probably the caregiver, came to know about the diagnosis in the morning, and then they are coming to our OP in the noon with the bad news that they, that they received, probably from the other department. So they come with a lot of emotional distress, they come with a lot of the psychological distress, and they come and sit in front of us, right? So that is the time where you're going to start doing the assessment. Probably at times you need to give counseling. So I usually do it, probably when I do the initial assessment. Probably the first thing that I would do is that I'll take them to the next room, or probably take to them some private space where the other patients or probably the other people are not watching, and we'll have an initial talk and we'll have an initial assessment. Now, it's always like when you break the bad news, the first few days, it won't be easy to accept for them, right? So these period, they might need a strong emotional support from our side. Probably if it's more, we also refer it to the psychologist. So there are cases where we have to refer it to the psychologist. But over the period of time, it changes. So this is just an example I'm putting in. There are also other things along with that. So over the period of time, it changes. Change over the course of illness, they'll start accepting that, okay, this is the prognosis, this is the diagnosis, yes, this is going to happen. So the psychosocial needs, the needs of patient, counseling is one such needs. There are other needs which we will see in the next slides. Now, sources of information. So what type of sources of information that we collect during the initial assessment? So first, we ask about the patient or the caregiver, and then the collateral sources like about friends, about relatives, about neighbors. So basically, as I said, it's not just the patient. So that is what differs from everywhere. We look into the whole family, whoever is connected with the patient. It can be their friends, it can be their relatives, it can be their neighbors, anyone. So we look into the whole contributing factors to the patient. So that's what we look. So initially, when we do the assessment, we the first thing that we do is that we make sure that whether the patient or the caregiver knows about their diagnosis. So that's the first thing that we do. And we'll make sure if they know, yes. If they don't know, we'll discuss among the team. If they are not aware about the diagnosis, or probably if they are not aware about the prognosis, we say it's pollution. It's like an agreement that we have with the caregiver, or it's an agreement that we have with them that we are not breaking the bad news. So we have this team where I said the multidisciplinary team, we sit together and we decide, and then we'll say whether we have to break the bad news or not. So that's the first thing that we do, and then we comes to the patient, about the patient, and then we'll start with. So we usually don't directly talk with the patient, but we usually talk with the caregiver first. So then we talk about their friends, relatives, neighbors, and also home visits. So home visits is the place where a full assessment can only happen in the home care setting when you visit the home. So what happens here is that when a patient comes to the OP, you can't always believe what they say. Sometimes, they come and say that I don't have, money to travel and come here. They say a lot of stories. A lot of things would be correct, accurate, but also at the same time, unless and until we do a home visit, unless and until we get a full assessment, only then we'll understand whether what is the actual problem area. We can identify the actual problem area. So that has happened many times. While I was also doing working in medical college, so there were few cases who came to me and told about a lot of things, which I felt like I had to do a special visit. So we do have a special visits here. Like we can, if at all we believe or we think that there is a requirement of visiting a home, yes, we can do. We have an option for that. So I usually do this home visits to get a full assessment. Only then I can understand what is the key area, the problem area where I need to do the intervention. So that is also very important. Now, these are the areas of assessment. So we assess the patient, the family overview, the insight, family structure or dynamics. What are their socioeconomic status right now? Environmental assessment, psychological distress, spiritual impact of illness, interventions and plan. Now we'll go through all these. What are patient and family overview? So for initially we take the basic demographic details, their name, their address, where they're staying right now. Sometimes we get patients or bedridden, so we have this home care service. So we'll take the landmark where we can reach out to the patient and the caregivers contact, all of the basic things, and then occupation before and after illness, very important. We do take that. We have an option of that. Then the primary caregiver and relation, who's a primary caregiver of the patient and their relation. Then comes the insight, diagnosis, prognosis, palliative care, patient and family. So this is a very important area where we give a lot of stress, because this is the area where we need to know whether the patient or the caregiver knows about the diagnosis, knows about the prognosis, and most importantly, palliative care. So here I want to tell one thing. In my few months of work experience, the patients that I've been seeing every day, I would say 80% of the people have no idea about palliative care. And in the assessment, we do have a column where we'll include whether they are aware about palliative care or not aware about the palliative care. So it is very, it's very saddening to know the fact that people are not aware about the palliative. What care we give. They think palliative care is something to reduce their physical pain. So every time when I get a patient, the first thing I'll ask would be, do you know anything about palliative care? So the initial response, the response that I get is, yeah, this the doctor said that I have pain. Like he has pain, she has pain, my mother has pain. So I have to consult here and get medicines and get a pain relief. So this is what we all know about palliative care. But apart from that, there's a lot of services that we actually do that makes us the whole palliative care. Now, the family structure and dynamics, genogram. So we'll come and see in the coming slides more about genogram, what is genogram and how it helps in taking the psychosocial assessments. Now, family dynamics, what are the support systems that they have, and the history of illness in the family. And it all helps, it all comes under genogram. We'll also get to know if any other family members has the same history of illness as the patient. Now, so genogram is basically a family tree, right? So Murray Bowen is a person who discovered it, and it's a graphical representation or a pictorial representation of a person's family over at least 3 generations, which tell us about the structure, dynamics, strength, and the resources. So usually in genogram it comes 3 generations, but at some point of time, when you have too much crowd or too much patients in the OP, we might not be able to take the whole 3 generation of the family structure. So during the time, if at all the grandparents are still alive, yes, we do take it, but we make it a little short just to get the most important parts of the genogram, the information. Now, the types of information in the genogram would be name, age, educational or occupational profile, and emotional relationship. So I'll just go through, these are the symbols that we use in genogram. So for male, it's a square pattern, and for female, it's a circle, and married, you can see, it's just a normal line. So that's how we draw married couple. Then if it's separated but not divorced, we give a one slash, just one, and then if it's divorced, legally divorced, then we put 2. Now you can see the next box where if it's adopted child, there can be situations where there'll be an adopted child. Then you can see a foster child, how we give in foster child. Then pregnancy, that comes most of the time, and stillbirth, miscarriage, abortion, twins. So twins and pregnancy, I think most of the times are used to come. And sometimes people make it very confidential about their miscarriage, abortion, and everything. So most of the time they do not reveal it. So mostly in the initial assessment, they do not reveal it. But they usually, that's what I said, it's an ongoing process. So throughout the journey, maybe at some point of time, they'll reveal that, okay, that time I had this abortion. So we'll make a change into the genome, or probably we'll redraw the genogram. That's what it happens. So anyone has any doubt in this pictorial representation? Anyone? Yeah, anyone? Any doubt? Is that clear? Okay, we'll go. So this is how we give the emotional relationships. So for example, if a patient or the family members are having a very normal or plain relation, like it's neither no abuse or any conflicts or the normal relationship, then we'll have a straight line. Now, if it's not too close but close, they're friends and they're close, and then we use the green color and then we draw those dotted lines. If it's too intimacy and very close, if it's very close, we give two lines with green color. Now, hostile conflicts. So there are a lot of conflicts and hostile relationships that used to come in most of the cases. And then violence. Violence can be like physical, all that it comes violence. And then emotional abuse. There are a lot of emotional abuse relationships that comes. Then sexual abuse, neglect. Hope this is clear. So this is how so the major use of genogram is that when a patient comes and talks about their family structure, we don't have, unlike any other OPs, what we usually see is that people come and then they consult the doctor and they get the medications or probably some other treatment or advice for taking scan, test, all that, and then they'll go. And then they'll come probably in after 1 or 2 weeks. So that's what it happens, right? But here we take this whole psychosocial assessments. We have this regular follow-up. But also we have a lot of patients coming every day and we don't have enough time. So that needs to be taken into consideration. And for that, we use this genogram to use the time, to not to waste the time writing the family structure in a paragraph. So when you make a genogram, you will get an idea about the whole relationship that happens inside the family. Now, so this is a very simple way of genogram for you to understand. Now, so how do we identify our patient? So as you can see, Sindhu age 40 with a cross lines, she is our patient. So that's what we actually do. We draw the cross lines. So that's how we implies the patient. So that's how we understand that's a patient. Suppose if there are two patients in one genogram, we'll put an arrow towards our patient who's registered at our institution. So here, as you can see, Sindhu is a patient. Now, Mohan and Leela is Sindhu's parents. So that's where it starts from. Mohan and Leela is Sindhu's parents. And when you can see Mohan and you can see a cross mark. Cross marks indicates the death. He passed away. So Mohan is now passed away. He's no more. Leela is there. She's now 60-year-old, is a homemaker. Now, you can see on both the sides, Sindhu, on right side, you can see Raju, a coolie worker, and left side, you can see Shaji, a mason, right? So it means that Sindhu had first husband, name is Raju, who was a coolie worker. He passed away, and they have a child, Sharan, who is now studying in 11th grade. Later, she married Shaji, who's a mason, and they have twin, Amal and Vimal, who's studying right now in 8th grade. Now, Shaji's parents is also there, Kumaran and Laila. They are also passed away. So this is a very simple format of genogram. Is that clear or is it complicated? Anyone? Understood? Any doubts you can openly ask. Shall I move on to the next slide? Yeah. So this is one genogram that we've actually used here in Thailand, India. So this is actually Sindhu's same genogram, but a little more showing the emotional factors. So as you can see, Mohan and Leela, and you can see Indu and Sindhu. So you can here they've added Sindhu's two sisters. So Sindhu is the second child of Mohan and Leela. First one is Indu, then Sindhu, and then Bindu. So here you can see is that Indu and Sindhu is having, I'll just go back to the previous slide so you'll get an idea about the relationships. Yeah. So they have a very intimate relationship. They're very close. You can see with green two lines. Yeah. So it means that Intu and Sindhu, also Bintu and Sindhu, they both are having a really close relationship. Also, Sindhu is having a really close relationship with Sharat, who is the son of their first husband. Now let's see the red mark showing. So Sindhu's second husband, who is Shaji, he has a elder brother Subhash, who's a plumber. Now he has some conflicts with Shaji. That's what we understand from the genogram. He has some conflict with Shaji. Also, Subhash's wife Veena, sister-in-law of sister-in-law of Sindhu, has some conflict with the first child, Sharat. So from genogram, you can understand, rather than writing it in paragraph, you understand what kind of relationship they have. I hope you get it. Any doubts? So I move on to the next slide. Okay. So now echo map. Echo map is also an important factor that comes in the assessment. So, so it's been discovered by Anne Hardman. So it's a pictorial representation of patient's family in its social environment, a relationship with the larger society. So it's a snapshot view of important interactions of patient's family with other systems, groups, extended family, individuals, organizations, associations, etc. So basically, when a patient comes, this is also important, education level of other family members. Yes. So it's a snapshot view of important interactions of patient's family with other systems, groups, extended family, individuals, organizations, association, etc. So basically, when a patient comes, they might also getting some other help from other organizations. They might be getting some other help from or support from their society, probably from their panchayat, or probably from their municipality, from their corporation, or probably some political help, from the politicians, or they might get some help from their friends, individuals, some specific organizations, association. So we need to add that as well. We need to know from which all sources or which all sources are getting the help. So let's see this one. Yeah. So here also we'll give different lines saying if it's positive, tenors, stressful, energy flow, arrows, line thickness, which shows the intensity. So usually in a family unit, they might be getting health services. The neighbors might be helping them. Workplace, from their workplace, they might be getting some help. Some government services, community services, some religious institution, usually church, all that. Some from their friends, some clubs, or from school, probably like the patient's children. They might be studying in some school, and probably the teachers and the principal, they can help the family knowing the illness. Volunteers. So all these also we should understand. So in order to avoid the time taken for writing it as a paragraph, we use echo map. So this is one that we have done here. So you can see this is one patient. The patient is a female. You can see the cross lines, and they have two children, one male and one female. So it's a 4-member family. Now let's see what kind, from where are the places that they're getting the help. So from church, they are getting a really great help, I guess. Yeah, see the line thickness is intensity. Yes, they're getting a really good help from church. Also from panchayat member, you can see it's not really, they're not getting any help or anything from them. Then neighbors, no, it's not. Volunteer, yes, they are helping, but not really. Youth organization, they are getting an intense help from the youth organization. School help them. So as you can see the arrows, they put 2 arrows. So it means that both of them are helping each other. Like both of them are helping each other. The friends help and they help each other. So that's what it has. College has an intense way of helping them. Public health center, no. Colleagues, yes. So basically the patient's husband, he is probably working somewhere and the colleagues helps him. And then self-help groups, also giving some help to the patient, but not so much. So this is an example of echo map where we'll understand from which sources are they getting different type of helps. Yeah. So any doubt in echo map? Let's move on to the next slide. Now, caregiver, very, very important part in a patient life, in a patient family, right? So there are only 4 kinds of people in the world. Those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. So it's from Rosalind Carter. So respect those individuals and acknowledge their complex role. Yes, this is a very complex role. We think, oh, it's just a caregiver. No, it's not. And never dehumanize them by calling them bystanders. So this is a very, very important part that we actually follow every day in Parliament. We never call them bystander. And people still have a misconception that, they call bystander, not caregiver, right? So it is also very important that the amount of work or stress that they go through, seeing the condition of the patient, taking care of the patient in the worst situation, even they go through emotional distress, they go through psychological distress. So we need to really respect caregivers. So that's very important part in here. So that's what I said earlier. We do not look just into the patient side, or we don't address the patient problem, but we also address whoever is connected with the patient. It can be, firstly, it can be a caregiver. The caregiver must be going through a lot of stress and other problems, which they might need a counseling, which they might need a support from us. Probably the other family members, their children. Now, next comes the socio-economic status. So we have a different, separate form to fill socio-economic status to know the financial, the current financial status of the patient. So there we address their adequate food, whether they're getting adequate food, whether they have clothing, whether they have shelter, whether there is a breadwinner in the family. In most of the cases, I say there are no breadwinners in the family. So the breadwinner used to be the patient. And because the patient is bedridden, the wife or the husband, whoever it is, are not able to go for work and they have small children. What do? There are only 4 members in the family and there's no breadwinner. Where is the source of income comes from? So there are a lot of questions there. So that's why we do take these assessments and see what kind of intervention we can do in there. Who controls the finances, the source of income, debts. They might have taken a lot of debts for their treatment. We go in depth of that and understand why they've taken the debts. Even we have a column where we'll explain what was the reason for taking the debts. Is it for treatment? Is it for any other purpose? There are also other purposes like house construction, house modification. We make sure that why did they take the debt? Why did they have the debt? Then the social support, whether the government schemes, local financial support, are they receiving this government? Are they getting this government schemes? Or are they aware about the government schemes? Or we are the people who need to make them aware about the government schemes. And what about the local financial support? Are they getting the financial support? As you can see, from Panchayat, they get a lot of things for free. Like, for example, diapers, all that things, some medicines. So are they aware that they get it from the local financial support? They're getting it from their Panchayat. They're getting it from their nearby municipality or corporation, wherever, or the health sector. We need to look into that. So during the initial assessment, we get to know all of this and the education of children. So whether that's a very most important area where we usually do the more intervention, because as I said, if the breadwinner used to be the patient used to be the breadwinner and they have 2 small children or probably someone studying in 10th and 12th standard has a wife, but wife is not able to go for any work because they have to take care of the children. And now the children are like, I've seen cases where the children had to discontinue their education because they don't have a financial source of income coming. Very brilliant children, very brilliant children. What do we do there? So there we understand the key area of the problem. Yes. So the children who used to study well, now they're not able to go to school because they don't have fees to pay. They don't have money to pay the fee. Because the breadwinner who used to be the breadwinner is now a patient, is now bedridden. And mother is not able to go to work because she needs to take care of the patient. So there we understand the problem. Yes, that is a key area of the problem. And what happens is that there comes the emotional pain of the patient and the family. They start having psychological, oh, my children is not able to go to work. Go to school. What about their, education? What about their future? Now we need to look into where we need to do the intervention. So therefore, looking into the patient's socio-economic status is also very important. That's why we do have an interdisciplinary, a multidisciplinary team to do the clinical part, doctors, nurses, to do the psychosocial, socio-economic, spiritual, we have social workers, and we have psychologists. Now, the environmental assessment, the type of house, they might be having own house, but also they might be having rented house. So there are severe cases that comes usually in rented house. They took rented house when they were financially stable, and now they're not able to pay the rent for the past 6 months, and they're getting emotional abuse from the owner. There are a lot of cases that have come in front of me saying that we have no idea how we're going to pay the rent, in need of repair. Sometimes it would be the water would be leaking. It can be just, restored any time if a rain comes or a strong rain comes. So there are possibilities of that. They don't know what to do next because they have no idea, because they have no money with them, no financial income. Now, position of the patient in the house, overcrowding, ventilation, light. Now, kitchen, open food storage, smoke, disposal, all that. So disposal cases, a lot of things comes there. Water supply, frequency, distance, method of collection, transportation. So we look into all these areas. As a social officer, we look into all these areas of the patient's family, how they're doing, and access to main road, hospital, pharmacy, groceries, whether they can access to the main road. So that there is one patient, in fact, 2-3 weeks back, I think he passed away. So there was no road. We literally have to walk on top of a canal where this water is flowing, and it was a very small way. It's not even a road, right? It's like a wall. On top of the wall, you need to walk. Even if the patient needs to go to hospital, he needs to go through that way, and it's very small. So we think of that. Is it accessible to main road? Can we take the patient to hospital? Is there any nearby pharmacy? Is there places where they can go get groceries? All these things we take during the assessment. Now, psychological distress, mental health, very important. So I think this is a very key area where we usually do the intervention for mental health. Emotional well-being, anticipatory grief, coping mechanisms, all these areas. Usually, these areas are being covered by the psychologists, also the medical and psychiatric social workers here. Yes. Now, spiritual assessment, the connection, strengths, and comfort, hope and concerns, meaning and joy. Now, when it comes to spiritual, it's not really the praying or church or temple, but spiritual can be of different types. For example, a person, so that is always a misconception. We think that being spiritual, can anyone tell me what do you really mean by being spiritual? Is it going to church? Is it going praying? Is it going to temple? Or anyone has another opinion or different opinion about being spiritual?
Feeling internal well-being.
Feeling?
Internal well-being.
Okay, yeah.
Healthy
Then,
relationship with surrounding environment.
very good, excellent. Any more? Any more? What do you really mean by being spiritual? Apart from going to church, apart from going to temple, praying. Yeah, that is spiritual, yes. I'm not telling that that's not spiritual, but that is one way of being spiritual.
And being a spiritual means that you are being human, having empathy with the patient and with yourself. You're truly a human, and you can feel the emotions and you can connect with a human being. It's not going to the temple, whether you are treating how you're treating and how you're behaving with the other person. That is a real spirituality. You're giving due respect, making the other person feel happy, comfortable. That is spirituality.
Great. Any more comments? You can also use the chat box.
Emotional support, where you can get to interact with people, try to share this thing.
Okay.
Both ways. You can get support from those places also, like as you're showing here in your genogram, which are the areas where they are getting support. So these places also can be an area of support, both not necessarily monetarily, can be an emotional support where they can discuss, it's sort of what you call it as and other psychotherapies like your meditation or anything else which can be conducted there. They can help in the symptom management, stress management.
Excellent, 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 excellent. Yes. So being spiritual is in different aspects. For example, I believe that every day morning I wake up and I do gardening. I do gardening. And I'm so happy doing it. I'm so satisfied doing it. That way you can be spiritual. And it can be a specific person, as you said. So you feel talking to that person, you feel sharing your things to that person, you feel like going to that person is still there, can be a way of spiritual. Doing something that makes you feel like that's comforting you. It can be anything, like meditation, yes. Doing yoga, that can be spiritual, yes. So spiritual as such is not just going to church or it's not just praying, but it has a lot of other aspects. Connection, strength and comfort, hope and concerns, meaning and joy. So whatever that gives a connection, like you have one person who has you have a strong connection with, and then you can say they're spiritual, you're spiritual, yes, because you know that person is there. So you can probably tell anything to that person, you can go to that person. You think that person comforts you, and that gives you strength and comfort, spiritual, hope and concerns, meaning, and it gives a meaning and joy. So it can be anything. So that way it can be spiritual. Now, so spiritual assessment when it comes to the areas of assessment, the connection part. So who are the persons or communities you look to for support? So what role do they have in your care? Do you have an image of power greater than yourself? Has your life situation affected your feelings about yourself, your faith, or your relationships? So that way, connection, the meaning and joy. What has been most important in your life? What are you most thankful for? What makes or has made you happy? What do you feel the proudest of in your life? The strength and comfort. Is there anything that is comforting to you now? What helped you get through difficult times in the past? Who or what is your source of strength now? So that's what I said. Who is your strength and comfort? There'll be a person. It can be a person, it can be a thing who you're getting that strength and comfort from. So your source of strength. Is there anything that you hope for? Is there anything that feels unfinished? So all this comes under the spiritual assessment. Now, so now we'll move on to the intervention part. So these are the areas where now, once we understood the problems, the key areas of the problems, as I said, sometimes it will be education, sometimes it will be they don't have a source of income, right? So then we'll understand, okay, these are the areas we need to do the intervention. So these are the areas, usually what we do interventions, providing information. For example, when a patient comes with, I've encountered with one case recently where the patient and the caregiver do not know what is cancer. So when I asked, it excited me in a way that I asked, do you know what is this diagnosis? She said, the caregiver said, yes, it is cancer. And then I was a little curious why she's telling it like with no expressions on her face. And I felt she has a very genuine soul. And I felt like I wanted to ask whether the caregiver knows about what is cancer. So I asked, you know, what do you know about cancer? And she said, I know that my sister had cancer. Now my brother has cancer. Even my mother had cancer. And then people are telling this cancer. So I know that it is cancer, but she doesn't know what is cancer. She has no clue what is cancer. And at that point of time, probably they might need a lot of information. What is it actually? It is just one thing I'm putting into example, but there are also other things. They might not know about the other aspects. For example, how to give a proper caregiving. So some information about giving the care, the proper care. So we provide information. That way we do intervention. Listening, facilitation, rehabilitation. So when it comes to facilitation, so usually when in our OPs, we also get a lot of patients from other states, even other districts. Now, when we get patients from other districts or other states, it is always difficult for them to come every 2 weeks or every month to get the medicines and get the proper care. So palliative care is something that's supposed to get from the nearby places. Sometimes it will be a home care service. Sometimes they have some emergency or they might have to get a palliative care immediately. So probably if people from other states or probably people from other districts inside the state, we have a facilitation team over in Pallium India, the state facilitation team, national facilitation team. So for example, if it's inside Kerala, for example, if a patient that comes from Calicut, which is almost like 12, I think 10 to 11 hours drive. So if a patient comes from Calicut to Trivandrum, it is very clear that they will not be able to come every month because they have to travel so much. Sometimes even they have to bring the patient. That's not possible. So what we do is that the type of intervention we do is that we facilitate the nearby palliative care centers and make sure that they can access to it. But that does not end there. We also do the follow-ups every week, making sure that they're getting the proper care. And also, if you can go to Pallium India's website, you can take the directory. When you go down, you can take the directory and you can see the list of palliative cares across India. Even that would be useful for all of you. You can go through the whole state. For example, if it's Karnataka, you can go through, when you click Karnataka, you get the whole districts, and in each district, how many palliative care centers are there. And you can also find out the numbers, contact details. So either we give this to the facilitation team or social officers itself, facilitate it to the patients. Now, rehabilitation. For example, if you have a paraplegic patient who is an artist, suppose, but he doesn't or she doesn't have any income or source of financial help to grow in that area. So we, at that point of time, if the person is able to work, suppose if the person is not able, is on wheelchair and not able to walk, but he can do things with his hands. So we might look into rehabilitation. We call it as vocational rehabilitation. We'll see if we can make him do something so that he can earn from it, from what he knows. For example, we have a person who's an artist. He takes art classes and we have supported him. We helped him to start in a small room. We helped him to start art classes, and there are few children who are still there learning art classes from him. So he is earning every month. Lottery. So we've given a lot of people lottery sales, and we facilitated so that they'll continue with that. And probably some people are even good in English. They take classes. So we help them, we support them, we assist them so that they can get an income from that. So rehabilitation, we help them if the person is able. And also not just paraplegic patient. In fact, if we have a patient with CA, 4th stage, or having METs, or in the last stage of life, we also will see if, like the same example that I've given last time, if both of the children are very small and there's only one wife, there's only wife. So what we basically do is that we will try to see if we can provide some rehabilitation, or we can provide some kind of help to the wife, or provide some kind of education or training. For example, tailoring. We provide training so that she can earn some income. Even if there's something happens to the patient later, she can take care of the family. So we also look into that. These all comes under intervention, the last part. After the whole assessment, we come to this part. Then bereavement support. It's a very important part in palliative care here. So bereavement support does not happen in every patient, but if we think that the patient has severe psychological distress due to the loss of it can be husband or family member, the patient. If we think that the patient is going through strong emotional distress due to the loss of the patient, what we basically do is that after like 1-2 weeks, I think after 14 days, we go and we meet the caregiver, whoever is going through this emotional stress. we go to home, we'll do a home visit and we'll give a bereavement counseling. There will be a psychologist, there will be a social worker, and probably might be a doctor, nurse. Yeah. So we do that. We give bereavement counseling because we know that this person needs an emotional support. This person needs an intervention, psychological intervention there, because we know that the person is not able to overcome the loss of the patient. Follow-up, regular follow-up. Even after the loss of patient, we do not stop there. We keep looking on to the caregiver, the children, whether they're getting proper education, whether they're doing fine. So all that we look into. Even after the loss of patient, we still do the follow-up. Supportive counseling, yes. So usually this counseling comes when the first time they comes to know about the diagnosis or the prognosis, or if they are going through emotional distress, seeing the condition of the patient, can be anything. Then psycho education. So all these comes under intervention. So basically the first initial assessment, and then we have a lot of follow-ups, and at last we come to the intervention when we identify which is a key area of the problem, and then we do the intervention and we'll see. So these are the most of the interventions that we usually do here. Now, assessing psychosocial and spiritual suffering. So how do we assess the psychosocial and spiritual suffering? First, we'll have a purposeful observation, very important, purposeful conversations. So as I said, when a patient comes to me first, it's not I ask them what is your name, where are you coming from? No, that has no relevance in the initial assessment part. That has no relevance. The first thing that we look into is their body language, their expressions. We'll do a purposeful observation of the caregiver of the patient. And we'll see so we'll get to know whether they're going through an emotional stress, whether they're going through any depression, whether they're upset. And also we'll feel that they have something to say. Sometimes they hide something, they wanted to say something. So observation is important. That way you get a lot of things. Then purposeful conversations. So you have a purposeful conversation. These are the two ways of assessing psychosocial and spiritual suffering. So if it's inaccurate or incomplete assessment, suppose if it's not an accurate or not a complete assessment, then the goals and the interventions will be inappropriate. So when you start an assessment, it has to be accurate and it has to be complete. Because our goal is to identify the key problem, the key area, and then we do the intervention in the end, right? So for that, from the initial assessment, it has to be accurate. Whatever information that you collect should be accurate and complete. And that's where I said, at some point of time, you feel like the information that you receive from the patient is not, or probably from the caregiver is not adequate, or you think that there's a requirement of doing a special visit in order to make sure that this is an accurate information that is received. So we do special visits to make it. Only then you can come to the appropriate goals and interventions. Now, let's see a case study. A 56 years old lady, Mrs. Let's say A, has been diagnosed with CA breast in 2016. Now, she had undergone mastectomy, it's a breast removal surgery, referred for pain management. She looked very anxious and had no idea about palliative care. Then, see, she has a past history of diabetes. She's been diabetic since 12 years. Coronary artery disease, fracture on leg due to fall in 2019. See, it's not just CA breast. She is a widow and her children are having a hostile relationship with her. And she lives alone in a rented house. See, one thing, she is married, she's separated from her husband. She is diagnosed with CA breast and she had this breast removal surgery. She has pain. She looked anxious. She had no idea about palliative care. Along with CA breast, she is diabetic. She has heart disease. She's having fracture in leg, probably not able to walk. And she's a widow. And the only children that she has, having a hostile relationship with her. So it means that they are not living with her. She lives alone in a rented house. Now, So let's discuss what are the important areas to be assessed from the point of view of total pain. So we know that total pain comes in physical pain, psychological, emotional, socio-economic, spiritual. So now I want you to tell me what do you think are the important areas to be assessed in this particular case? In which all areas we need to assess in this particular case? I want answers from everyone. Probably you can make it as a very interactive session. So I want you to give me an idea like what are the key areas that we need to assess in here? All areas. So can you specifically mention what are the areas?
Psychosocial domain, spiritual aspect,
Yeah. Psychosocial aspect.
spiritual, economical,
Economical, very good. Attend to physical, making her know about the way how palliative care works. Identify understanding of diagnosis and prognosis. Okay. Great. Pain management, social support, economical support. Okay, good. Any more? Then supportive feel,
emotional aspect,
helping to improve. Okay, emotional aspect, yes. Anxiety, depression, yeah, good. Right, so let's see. Now, in fact, yes, to correct, we have to look into every areas of this. One thing is, yeah. So let's see. Physical, when it comes to physical, she has physical pain. She might have physical pain, yes. She might have fatigue, lack of sleep, difficulty in walking because she has fracture, body image issue, very important. Very important. She has a breast removal surgery, so that's a very important factor that she might have a body image issue. That can be the possible areas, right? Now, that comes under physical and then psychological isolation. Very important. So these are the key words we need to understand here. She's a widow. She has her children is having a hostile relationship with her. So she is all alone inside her home. She's having a total isolation. So the isolation can bring a lot of other problems. Emotionally weak. She must be emotionally weak. Anxiety about future. What? I'm alone. I'm having fracture in leg. I'm having CA. I'm a CA breast patient. So what can happen if something emergency comes along next? The few coming days. And future unclear about the prognosis and palliative care. Very important. Yes. I think Dr. Arvind has mentioned about making her know about palliative care, very important. She might be not be having a clear idea about her prognosis and what is palliative care. So when you really explain, making her know what is palliative care, she get to understand what is the type of care or support that we provide. Distress due to multiple illness. It's just not clear breath, but she has multiple illness. That distress might be there. Socioeconomic, strained relationship with family. Her social life is very weak. Unable to go for job. She's a patient. There's no one to go for job. She cannot go for job. Financial instability, house rent. So she is living in a rented house. So how can she pay the rent? Because she is not able to go for work. Her children are not having a hostile relationship. Now, we have to see how she's going to live alone. How is she managing her all things, making food. Low accessibility to hospital, absence of caregiver and support system. Yes, very important. She doesn't have a caregiver. She doesn't have a support system. Now, when it comes to spiritual, extreme spiritual distress. Why all these sufferings? Yes. So this is a very key area, very common that I encounter every time, most of the time when I get a patient. So I still remember while I was doing my internship with Regional Cancer Center, there was a very beautiful mother, who was admitted in the ward. So every day I used to go for rounds along with the doctor, and he introduced me to that mother. She looked very beautiful. She has a daughter. So even she was there with her, and I used to talk to her every day. She was very sweet, very humble, down to earth person, and she was emotionally very weak. So this doctor, in fact, sent me there to learn how to deal with such situations. And so initial time I talked with her, it was very difficult for me even to cope with the situation, because every time I go, she says that, um, why did it happen to me? Why I have to go through all these sufferings? So she started saying about her past. She said, before we used to have, we were very financially stable. We used to have a lot of money. My husband used to work abroad. We used to have a lot of people inside our house, neighbors, relatives, friends. And we used to live in a really good house. And even she mentioned one thing that she, in fact, helped one person who met with an accident, immediately took him to hospital and saved his life. She explained to me that she saved one of the person's life from an accident, and she is an amazing cook. In fact, her passion is to cook, especially biryani, I guess. So she used to cook and give it to the neighbors and all. She has done good things throughout her journey. And now, due to COVID, her husband lost his job and had to come back. Due to the treatment and other things, they had to sell their house, sell the land, sell everything that they had. And this daughter's education got discontinued. She joined for BCom and she couldn't go because she was the one person who was taking care of the patient. And then she said, no one, not even one relative came and inquired about me, what's happening. Not even one called. When we had money, when we had everything, there were more people to take care of me or used to be in my house. Now we have lost everything. We don't have money. Now I can't see anyone, and I have done so many good things. Then why I used to pray? I used to go to temple. She said I used to go to temple, and why I have to go through all these sufferings? Do we have an answer to that? Can we actually say anything or giving a reply to that? No. We can only remain silent and accept, just listen to them. That is what you can do in most of the times. There is no solution to such comments that they give or such traces. If they ask why all this sufferings to me, lost faith in God. I used to go to temple, I used to go to church, I used to do all these things, but now I've stopped it because I don't believe in God anymore. Loss of connection with family, no significant person in life, no memorable, joyful events in life. So these are the areas that can be assessed in this particular case study. I hope you understood. Any doubt? Yes, we'll move on to the next. Now, these are the possible social impacts. Can be social isolation, dependency, financial instability, lack of social support, debts, loss of work, interpersonal issues, inadequate facilities, which I think we've already discussed all these way back. Possible psychological impacts, feelings of shock, uncertainty, hopelessness, anticipatory grief, poor insight, anxiety, suicidal ideation or wanting to hasten death. Very, very important. We encountered with multiple cases saying that or giving us hints that they have suicidal ideation or wanting to hasten death. There we give more intervention, we do more intervention. Also, we include the psychologist to give a counseling over there. So these people are considered to be vulnerable, and we see them, we give more importance in such area because the patient that we get having suicidal ideation, we somehow we try to make them come out of that thought. And we'll do more counseling or probably make them involved in some activities or giving them some hope, like, to do something or kind of motivation. So the suicide ratio is very high. It's huge in palliative care, people with pain. Suicide ideation can be different, It usually comes when the pain is severe. So there was a very saddening situation at where I done my OP. So this daughter came and told that just when she usually sits with the father, and just when she went to take medicines, I think medicines or chai, tea for the patient, she tried to cut her vein, and then they had to take it to emergency casualty. And I asked why was it. So I wanted to know what actually made him do that. What are the thoughts behind his suicidal attempt? And when I had an individual session with this Sachin, this father, and I didn't talk about anything related to his suicidal ideation, but rather I talked about a lot of things where he, at one point of time, he actually opened up to me, saying that I am so upset that my children had to go through this situation taking care of me. It's so saddening for me. And I feel like I'm a very big burden for my children. They're not able to go to work. They always have to be with me. And also the pain I'm going through, I can't bear it. So the kind of pain that I'm going through, I can't bear it. So there were multiple reasons which actually made it feel like, why do I have to be? So that's where we have some intervention being done. Yes, for pain management, we can give them that, we can tell them that yes, we do have medications for reducing the pain. A little comfort to the pain. Also, we'll see what kind of emotional support he needs. So we have multiple cases coming from suicidal ideation because of multiple reasons, in fact. Poor coping with the illness. So psychosocial and spiritual suffering is real, but can be difficult to recognize and treat. So this can manifest as physical complaints as well. So it is very important, and that's why we have a multidisciplinary team that consists of medical social workers, psychiatric social workers, psychologists. Because when you do an assessment, you go in depth and understand the patient, the psychological part of it, the emotional part of it, and sometimes it's very difficult for you to understand because they'll come up with physical complaints, which would be actually, in fact, is this something related to their psychological, spiritual suffering. So you need a lot of assessments, you need a lot of work and effort to understand what what the person is actually going through. Now, we have vulnerable populations. So how do we include what kind of population, what kind of people comes under vulnerable population? Living alone. So for example, if the patient, just as the case study that we've just read first, if a patient living alone comes under vulnerable population, elderly without support. We have many cases with elderly couple without any support. Even if they have children, no, they don't. They're not. They are somewhere. Even if you try to contact them, they say no. I'm not really because I don't. They don't respond most of the times due to multiple reasons. Single parent, multiple patients in a family. So that is also considered to be vulnerable. And we do have some families where there are multiple patients in one family living in one house. Victims of gender issues, domestic violence, physical, verbal, psychological, sexual harassment. Even that's a more confidential. So we don't really discuss it with everyone, but we sit as a team and usually discuss it with the team and see what we can do on that. Individuals with mental health issues, very important. Individuals with suicidal ideations, we just talked about it. Socially isolated. So that is a very common area. People usually gets isolated. So with the neighbors, relatives. For example, I know a patient who used to go every day to nearby a small tea shop, sit there, read newspaper. Now he is not going because after knowing the diagnosis. But we in fact motivated because he can walk. In fact, he can walk, and so we motivated him to go again. So we can do that. That's another type of intervention we can do. Substance users in family, very important. Individuals in extreme poverty, lack of food, water, shelter. So all these comes under the vulnerable population. Now, so it's just thought of including this here. The inability to acknowledge personhood, the insensitivity of not acknowledging personhood can be psychologically devastating. So thought of putting inside this would be appropriate. This is a quote. These are final words for final days. So these pictures are taken with the consent of patient and caregiver. So that's why I'm displaying it here. So you can see this is Pally in India, and you can see this is a patient and patient's caregiver, the wife. So in fact, we celebrated his wedding anniversary. He was under UL, end of life. He had very few days left, and we couldn't wait for a week because I think their wedding anniversary was a week later, but we couldn't wait for a week because he was considered under EOL, and anything could have happened in a week. So we thought of doing it a week before. So we ordered a cake, and this was the first time. I think in 25 years, it was the first time they celebrated their wedding anniversary. They were very happy and excited, and unfortunately, after 2 days, he left. He passed away. So maybe it's just the last wish, or probably that happiness we had. The very little thing, very little moment they had, but forever he was happy, he was excited, thinking of that because they're doing it for the first time. Now, see, these are the vocational rehabilitation. As I said, we also do help people, patients, family to start something of their own, and they can, get some income from it. So goat, you can see goat, we provide goat, hen. Okay, out of that they can get eggs, and they can make it a business. Then tailoring, all that umbrella making. We have lot. They also make I think earrings, bangles, all that they make. Even in Parliament, we do have a section where we keep all the paintings, all these umbrellas, lotion, all that the patients make, and we sell it. And we make use of this money for the patients as well. So these are the types of vocational, and now we are moving, like we are going in depth of agriculture or something more that they can actually, get a source of income. We're actually working on that, in fact. And support for children, education. So we do have educational supports in Thailand, India. Not just medicine support. We have medicine support. We have vocational rehabilitation support. We have aids and appliances support. For example, we give wheelchairs, stretchers, then diapers, all the things, whatever that they need as an emergency, we provide that. But as I said, we do a assessment, a deep assessment, probably with a special visit, and understand about the family more. Also, we support children. We know that after the assessment, we come to know that okay, the children are not able to continue their education, even if they want to study, they're very good at studies academically, but they're not able to go to school or college because there's no financial support. So for that patients, we understand these groups of people, and we do have a budget. We provide some educational support to them. So these are the ways of interventions that we do. We also have counseling. 2-3 months back, we had a summer camp for 3 days for all the children of the patients here. We had it. Like almost 45 to 50 children were there. We gave career counseling. There were a lot of games and activities. It was a really nice, amazing session for the children. Now, so always remember, evaluate our interventions. Very important. Assess how the patients and families are benefited. So it's not just doing all this, but what you need to evaluate your interventions. So whatever that I've done, you have to evaluate it, assess whether it's benefited to them, the patients and the families. So for that, I said we do the frequent follow-up to know that the patients and families are benefited out of the help that we provide. Assessments have to be revised and updated. Very important. So usually, yes, one more thing that I missed, we also give food kit support, not just educational support, but we also give food kit support. For example, if we know that the person, suppose we have two patients in a family, one husband and wife, both are having CA, cancer, and they have 2 children, but we don't know where are they. They have no contact with them, and they both are in 4th stage, and they don't have any. But I think the wife is able to cook, but they have no source of income. They don't have any money to get the food. So we give them. So we assess it, and we do a special visit, and then we come to a final decision that yes, this patient requires food kit. He is eligible for having a food kit from this organization. And also sometimes, as I said before, At some point of time, we need to stop that also. We always think of making the patient, or we always think of making the caregiver independent at one point of time, not dependent. For that, we don't provide this help continuously. We need to stop it somewhere, and we need to also look around the ways where we can make them independent. So assessments will be, for example, here food kit assessments are done, revised every 6 months. So every 6 months we'll assess it. Sometimes we do special visits and we'll update. Sometimes after like 1 year, after providing food kit for 1 year, when we visit the home, we get to know that they're also getting some food items, or they're in fact going for some job and getting it from other source. If we come to know about that, if we think that they're getting it from other source and they don't require our help or our food kit assistance anymore, we can stop it. So our whole idea is to make them independent at some point of time. But also at the same time, there are very few cases where there's nothing can be done. But we might have to provide for a longer period. Yes, it is also there. But there will be a frequent update and assessment on that as well. Reach out for help if needed. There is an art and science in psychosocial care, just as in medicine. So it's not just the medicine for pain management, but apart from that, there's a lot of art and science in psychosocial care. Yes, you can reduce the physical pain, but who will address their psychological, who will address their emotional, who will address their economic, spiritual problems? So that is also there. So for that, we have a big team over here who really works hard into exploring the possibilities of making, giving a quality of life for the patient. So I recently wanted to, before ending this, I just wanted to share an experience with you all. So we have an EOL patient, which is admitted here like 4-5 days back. So the kind of palliative care. So as you know that Rajgopal sir is the chairman of who founded Pallium India, and the kind of palliative care, what people think, the kind of palliative care that we give is, I'm putting it to one example that just happened like 3-4 days back. So there was this patient with CA endometrium admitted at our inpatient ward. So EOL means he has very few days left. So he just, while having a conversation with him, while having an assessment with him, I wanted to know what is his last wish. Where we can't go and ask what is your last wish. No, that's not possible. You can't, right? That's going to be very rude. But I just wanted to know what is his last wish. And I had a fruitful conversation with him, and I just asked him, is there anything that you would like to do, like anything that you would like to have, or anything like that? Any wishes, anything? Immediately he said, I want to watch rain and I want to have a cup of black tea and mixture snack. Immediately he said without thinking. So I was just looking around the sky and I was looking at it and I said, it's very sunny, and there's no rain. There's no possibility of rain. But he has asked for a very simple thing, just simple thing. He hasn't asked for money. He hasn't asked for anything else. He just asked that he wanted to watch rain. He wanted to have a tea, watching the rain, a hot black tea with a snack. So I was just thinking, he asked me a very simple thing. Why can't we make it happen to him? Why can't we fulfill his wish? So I discussed it with the team. So we have community social workers and medical social workers. We work together in community and inside the hospital settings, inside the clinical part. Immediately, so that is what palliative care is all about. As a whole team, the Pallium India stood together and we called to the water authority. We brought the water tanker and we thought we'll do an artificial raining, as you see in the serials and the films. And this whole Pallium India, sisters, social workers, nurses, doctors, everyone stood together and we brought the tangle only, and we in fact made an artificial rain, taking him and arranging the whole place for him to watch it from outside and making sure that he doesn't come to know that it's actually an artificial rain doing it for him. We made our cleaning chechis. They are like so lovable. That's what the palliative care is all about. They all stood together and made tea and brought mixture, the snack. And for like 10 minutes, he watched the rain and he had the tea, he had the snack, and he was very happy, excited. His last wish was fulfilled. So, this is all about palliative care. This is an intervention. So, what can we do from our part to improve the quality of life of the patient? So, this is just an example. So, with that, I'm concluding this session. Thank you so much. And if you have any doubts or anything to ask, yes, please go ahead.
Thank you very, very much, Devika. Exactly as you said, plenty of examples you've given. Can we come out of your presentation screen, please?
Yes, sure.
That is what is important, because giving, as I always say, giving live examples. And I will only second Devika's thing on telling that that's what Pallium is. I keep telling all of you, at least for 2 days or 3 days, you have to go and see, because in the organization there you have inpatient, outpatient, home visit. It's such a good team working, and you have to see to believe. That's what I would say. And because so much of thing is done out of the way, you like there, as she was mentioning, that halfway home is something what is there to give the patients the confidence. See, many maybe they would have recovered with the help of physiotherapy, psychotherapy, counseling, everything, but still they will have the fear. If, for example, someone is living by themselves, oh, I'm okay, but I don't know how confident and safe I will be. That is, to give them that also is what this halfway home does. That halfway home, they literally live by themselves, so that they gain that confidence also to go and live by themselves in their own home or wherever they go. Okay, so many examples she's given, and all those genogram, echo map and all makes your life easy. And always it's a team working. And just couple of things I wanted to just add on, like definition between religion and spirituality. That's an important thing to be aware of. Just in nutshell, no, religion is custom, culture, belief. Customs, not even belief, I would say custom and culture. It's done this way, it's done the other way. That is what is religion. But spirituality is meaning of life. What is meaning of life? That's beyond religion. Okay, so that is why you have a big difference between the two. They may, like a subset, no, they may have something common between both of them. But religion and spirituality are two entities to be aware of. As you all read a little bit more about it and go through and see patients, that will show more light, and you have special assessment forms and everything for all that. And anything else, I did check all the chat box queries and things. Is there anything left unanswered or anything like that? One thing last was clinical stage of disease and life expectancy determines extent of care. Definitely. As those were quite obvious, I didn't answer anything, because it depends on what is the stage of the disease, what has the patient understood, what is possible, and then only putting only multidisciplinary meeting wise, you will decide goals of care. Anything else? The rest all, no, like all things which were mentioned have been, like, anybody has anything that they typed and they didn't get an answer or anything like that, please unmute and ask, or anything you would like to clarify, please go ahead.
Ma'am, on that day you were been asking about morphine syrup, ma'am. Can I answer that today?
Yes, go ahead.
Morphine syrup, it's not been commercially available, but in our pharmacy they are preparing and giving it
Correct.
specially.
That is what, from what I was aware also. Thank you very much, dear. I was told that it
Uh,
is not officially available. It is only made in individual
Yes,
institutions.
ma'am. Since the dose was 2 milligram, it was a very
Hmm.
small dose. Tablet form is available as 10 milligram, and the patient couldn't break it into small pieces, 2
Cannot.
milligram.
Hmm.
So our pharmacy accepted to prepare a syrup which contained 1
2
ml of
milligram.
1 milligram.
Hmm.
So she
So
can
they
take
can
2
give 2
milligram.
ml. Hmm.
And for
Well,
maximum, they can prepare a 5 milligram syrup dosage.
that's what. So even for pediatrics, no, that's why syrup morphine is not officially available in
Yes,
bottles
ma'am.
in India. So thank you very much. So
Yes, ma'am. Thank you, ma'am.
what was known was, that is why I wanted to clarify. It's only because even pediatric patients, and breaking any tablet no into this 2 milligram and all, it's practically not possible. When it
Yeah.
comes as a 10 milligram, even when you make it into half, it's only 5, and that half will be 2.5.
Yes,
So
ma'am.
that is why. Okay, thank you very much.
Thank you, ma'am.
Ma'am, I need to ask a simple question.
Go ahead.
Ma'am, the presentation was very nice. Just regarding that case where all the concerns of the patient was discussed, that breast CA patient, the patient who had a spiritual concerns like why this happened to me and what is the cause, and Dr. Devika said that sometimes we have to keep quiet because is the listening only matters, or are there any answers, are there any counseling required for that? Because in spiritual, what should be done? Because these are the questions which are routinely asked by people, that why this has happened to me and I don't want to live longer. And so what should be the answers? We always keep quiet and there is no answer to it.
Let her answer first, and then I will come back. Go ahead, dear.
I have to speak.
Devika?
So yes, I understood the question. So in most of the case, when it comes to spiritual, it is their individual right to be spiritual. So there we cannot question. For example, if this my way of spirituality is, for example, traveling is my way of spirituality. So if traveling is my way of spirituality, you can't, it's not fair, it's unfair that to question your spirituality. So sometimes when it comes to patients, when they ask why did it happen to me, so in fact in some cases there's no answer for it. Like we can only listen to that and stay quiet, because it is going to be a little more confidential or more intense area where we can't give some answers or solutions to that. So spirituality is a very very intense area where it's the individual's right to be spiritual in any terms. And also when they say that, it's not, they're not telling it to expecting an answer. Usually they're not telling this expecting an answer. So we should understand that yes, it's because it's coming out of their emotion, it's coming out of their experiences, what they've been through. They tend to say that, and they're not expecting any answers from. So most of the cases we need to stay quite silent. That's what we also do.
Thank you, Devika. I was just waiting for you to answer, and then I thought, see, coming to, I think Kamakshi, Dr. Kamakshi was asking, right?
Yes, ma'am.
Yes, see, I will just add on few things. See, first, I will totally agree to her answer. A little bit more to add on to that. In that, from your query, first thing, no, for every question, there need not be an answer. Okay, this is something, our attitude, or like our nature, or that's how we have all grown up. For every question there should be an answer. There's no hard and fast rule for that. Okay, many times there are no answers, and no answer is the answer for that. Okay,
Right.
and then third thing I'll tell you, there are a few more things in this. See, if you spend time and find out, she just wanted to convey some guilt feeling or something. Oh, did I do any mistake, or what is that wrong I did? Am I going through all this? So those are in these type of situations, based on their individual cultural and religious beliefs, you may have, for example, if someone is a Christian, you can get someone from the church to come and do some prayers for them. That is where individually it varies. So when you can organize for some meeting or coming, even if they can't go, maybe they would have been a very pious person going to church every Sunday. Suddenly they are unwell, they can't go. So that may be a feeling. So in those type of things, you get based on the local, regional, cultural beliefs and procedures, you get someone to come and talk to them, pray for them, something like that. That will answer their questions. So those type of things. So if they, as she said, always they are not asking for an answer from us, but even listening to them, and we can suggest these things. That again, no, not everyone needs to say yes to what suggestions we are giving. They may say yes, they may say no also. Either way is fine, because that is where that individual, here there no autonomy comes. It's that person's will and wish. So we try to facilitate and accommodate and help them in whatever way is possible. So don't ever have a feeling just by listening to them itself you are answering their question. One thing, and next you can give some suggestions and see based on their based on their belief, ask them what is that you feel that might help you. Will any of these suggestions be helpful for you? So those type of things. And again, if you want a little bit more information, all those things, there are plenty of assessment forms for spiritual needs. There are not only local, international. Facet is one type. There are many types of already made questionnaires on belief, on spirituality and everything. So those can be used to assess. If you want to do a little bit more on that, plenty of stuff can be done on that.
Ma'am,
So complete assessment and things are there. Dr. Chidananda Swami, you can unmute and ask.
That could be a natural process of like that. Before they come to an acceptance, a denial, anger, denial. There's a part of that cycle. This is a way of denying that they have that disease or whatever the process they are going through.
Yes, definitely. That's what. So thank you, doctor. Exactly. These are all different. It's only stages. The acceptance will come from themselves itself. So, but it's a stage of, as you have mentioned, yes, it's truly another stage of it. It's an emotional expression. Like pain. So that is what. And one more thing, I think the penultimate slide, what she had, that physical, many times, the psychosocial and emotional is only expressed as a physical sign. We have been telling this again and again many times. I think in one of the first day or something and stuff, you had a short video in which a person pain was 10 by 10. So whatever they did and gave, and next within 3 or 4 days when they saw the patient again, patient was telling 10 by 10. Then they thought, oh, what is this? Is medicine? So then when they spoke to him, his main worry was he was the only breadwinner, and he had a child who was 10-year-old, not able to go to school because they couldn't pay fees and things. So then when they sat and spoke to the patient a little bit more in detail, and they found this, and then within 2 days, they sorted the educational, that way, Pallium does a lot, and all of you also can do. As I keep telling, only thing, in all your organizations, wherever you are, there will be plenty of NGOs or somebody else. From education point of view, today's world, many want to help, but they don't know whom to help. So setting up some connection between the person who wants to help, and we have patients or families who need help. So connecting them. So similarly, that patient's education was sorted. And 3 days later, when the team went to see his pain, he said that day was 2 by 10. They didn't change any medicine, nothing. It was the same medicine given, everything same. So it does have. So when I say, or when you hear all this, you may think, oh, am I making up stories? No, all of you will believe when you start practicing and seeing patients, that all those 4 components for pain are important. Even take us, the day when you are in low mood, your pain is high. When you're having 10 things, someone who has a chronic back pain or anything, and when they're doing something else, does the pain totally become zero? No, it is felt as zero that day. So these are things, as you all go ahead and see more number of patients, you will all understand and you will see to believe. Hope that was clarifying to some extent, Dr. Kamakshi. And if you want, like Devika, if further, those facet forms used to be there for assessment of spirituality, right?
Sorry,
Can't
ma'am.
hear you.
Sorry, ma'am.
There are some specific forms for spirituality assessment, isn't it?
We don't have a separate form as such just for spirituality, but we have included that also in the psychosocial form. So, since to reduce the time that we take for the assessment,
Correct.
we made it very small, and now we are addressing all this. For socio-economic, we do have a separate form, but we assess all the spiritual, psychosocial in one form, where there's a column given where we can point out the issue specifically. And we are not right now using anything, but yes, we use certain tools that to assess the vulnerability of the patient, as in terms of physical, psychological, economic, and spiritual. We have a valid tool we use. Yes, ma'am.
Like when I find, I have done a bit of audit and all these things on assessing spirituality. When I was in Riyadh, we had devised a form. I will have a look into it and send you. There are some basic two set international European forms are also there. I will have a look and put it in our group.
Please, that's going to be very helpful. I guess we can start using it also. We can look into that.
Yes. See, as you said, Devika, it is too extensive. Only if you want to do in depth.
In depth,
that
not
is, it is done.
everywhere.
But not everyone.
Yeah,
I wouldn't go ahead and do
exactly.
because see, not everyone gives importance to that.
Yes, true. True,
when need be, you go ahead and look into it in detail, will be fun. Just for Dr. Kamakshi's information, I will put them on. It's no worries at all. Okay. As there are no, I don't think anything else is there. Okay, then I'll pass it over to you, Anup and Shupriya to go ahead.
Thank you, Devika. I know personally, because I have been seeing you around, that you have had a very tiring day today, and literally she was running to take the session. Thank you so much. You just really made us proud. Thank you so much. Thank you everyone for attending the session and making the session interactive as well. With the promise that we will be meeting again with another different topic and yet another vibrant faculty. This is Vipriya along with Ms. Devika and Dr. Radha Venkatesh along with Mr. Anu signing off from the Tipsy Poha. See you in the next session. Till then, everyone take care. Bye-bye.